Good morning all. My name is Dr. PJ Madam Rafi. Today we are going to discuss about myocardial infarction. Okay, this is most common casual disease. So in myocardial infarction, what we'll have? They have two types of MIs. One is ST elevated MI will be there. Second one is non-ST elevated MI. Okay, ST elevated means in ECG we'll take an ECG. In ECG there will be ST elevation. So obviously we'll diagnose as a ST elevation. If there is not ST elevation, then the troponin test is showing heart injury. So we'll diagnose as a non-ST elevated MI. The treatment will be similar for STEMI and non-STEMI. But the difference is in STEMI we will use thrombolytic agents. What are those? We will see in following slides. Okay. So first we will discuss STEMI. Okay. The main will be STEMI, ST elevated MI. The patient will have chest pain. It has a radiating pain. Obviously jaw pain will be there. So we are sweating. All this will be there. So by taking ECG we will diagnose as STEMI. So how do you treat? First we will give the loading dose drugs. Loading dose we have, what will have? Aspirin will be there. Clopidogrel, atorvastatin. These drugs will give. So next along with this we will prescribe oxygen because of saturation will be dropping down. Then nitrates, it acts as an analgesic drug. Aspirin, antiplatelet. Okay. So to prevent clotting. Then morphine, it is acting as an analgesic. Along with this we will give thrombolytic agent, prevent the thrombosis. Okay. So we have to give the thrombolytic agent. What are those? Means STK, streptokinase, altiplase, retiplase, tenecteplase, urokinase. These drugs will be there. We will see all those in next slides. So coming to non-STEMI, the non-STEMI will not give thrombolytic agents. Other than thrombolytic, all other drugs like morphine analgesic will prescribe, oxygen we have to give. Then nitrates analgesic, aspirin to prevent antiplatelet aggregation will give these four monodrugs. That is monodrugs: morphine, oxygen, nitrate, aspirin. Okay. So in both STEMI non-STEMI, all are common except thrombolytic agents. What are those? We'll see in follow. So what are the thrombolytic agents we'll have? We'll have streptokinase. Streptokinase is an antibacterial agent. We obtain streptokinase from beta hemolytic streptococci. Okay, it is an antibiotic. Okay, so it is obviously it is obtained from bacteria. It is having an antigenic property. So it converts inactive plasminogen to active plasmin. This active plasmin will convert fibrinogen, insoluble fibrinogen to soluble fibrin. Okay, that means clot will be get dissolved. So which breaks down fibrinogen. So it can't be repeated in 1 year. What is the reason? Because streptococci is an antigen. It is obtained from the bacteria. So it is having antigenic property. So a body will develop antibodies. So if you given the same patient in 1 year, obviously antibodies will be there. So there will be no further effect. So to prevent this one, if patient is, that's why if patient is come to casualty, we will take history. He is having previous history of taking streptokinase. We will not go for streptokinase. We will go with other thrombolytic like altiplase, retiplase, tenecteplase. We will go other agents. Okay. So we should remember, we should ask the patient whether he is taking streptokinase previously for MI or not. Okay. Before prescribing streptokinase. So other drug other than streptokinase, STK, what will have? Tenecteplase, altiplase. Altiplase also, it is also tissue plasminogen activator. Thereby obviously it will dissolve clot. So it will be better than STK because these are recombinantly developed. This one. Main thing is what is the difference means STK will have bleeding tendencies. Okay, patient will have chance of bleeding. Previously is having any gum problems or gastric ulcer, they have more chance of bleed. So this compared to streptokinase, altiplase will be safe. Okay, they will also cause bleed, but gastric gum bleeding, these will be having a very little chance. Okay, that's why these are better than STK and dissolve old clots also. That is more beneficial. A patient having previous history of mild thrombus will be there. Those also will get dissolved. Then what are the T of altiplase? It is 5 to 10 minutes. These drugs are very expensive drugs. Okay. Next drug is retiplase. Okay, retiplase, tenecteplase both are altiplase analogs. Okay, so the mechanism of action is similar like altiplase. T of will be 15 to 20 minutes. Retiplase one. So here retiplase will be, we have to give 2 injections within a gap of 30 minutes. Okay. So in altiplase we will give only 1 injection. Retiplase will be given 2 injections. We are within a gap of half an hour. Okay. Next is tenecteplase. Tenecteplase similar, mechanism of action also similar like altiplase. TF will be 2 hours. This is also fibrin specific, more expensive. But this is given, has to be given 1 injection very fast rapid. Okay, within 5 seconds we have to inject the drug. Okay, this TF will be 2 hours, but one caution has to be taken. When patient is having high BP, we have to control the BP, then only we will administer these drugs, because other than these drugs will dissolve old clots also. So the patient having previous history of TIA, means transcellular ischemic attacks, any minor thrombus in the brain, it will get dissolved and it will lead to cause bleeding. So we should be more cautious when prescribing this altiplase, retiplase, tenecteplase drugs. Next drug is urokinase. This is also thrombolytic agent. It is isolated from the human urine. Okay, now it is developed from cultured kidney cells. It degraded both fibrinogen and fibrin also. It is safe drug. TF will be 20 minutes. Now mostly we are using urokinase. In some hospitals we are prescribing retiplase, tenecteplase based on the availability. Urokinase, compared to all these things, urokinase will be safe. Okay, this is a human developed only. So now we are developing from cultured kidney cells. Okay, thank you.